Good morning. Okay. Good morning. Hello. Hello, hello, hello. And a hush falls over this room of very energetic people. Good morning. This is so wonderful to see all of you here today. Welcome to Plaza Jewish Community Chapel's 14th, wow, 14th Bereavement Conference. It is truly an honor for Plaza to be your host today. You should know that over 2,000 people have attended Plaza's conferences in the 12 years that we've been doing this work. And we truly are honored in providing such a wonderful, thoughtful service to all of you. Thank you. Thank you. I truly speak on behalf of the community of Plaza Jewish Community Chapel when I say we, and I will get to who we are in a moment. But first, a very, very special welcome to Dr. Linda Emanuel, who is here today. Thank you so much for your participation. In addition to the participation of our workshop leaders. Obviously, from this wonderful turnout, we have brought the right mix together to appeal to all of you. You who are on the ground, who are the people dealing with families, with patients, who need you present at that most special moment in their lives. I have a very special heartfelt thank you to Howard Sharfstein, who you will be hearing from shortly. He is somewhat a member of Plaza's family. He has been with us through various stages in his life, and we're really honored to have your participation as well. And we would not be here today without this wonderful planning committee. The people on this list: Bob Wolf from Healthcare Chaplaincy, Sally Kaplan. There you are. Cecile Asikoff. Well, that was nice. Wow. Look at that. Cecile Asikoff. Rabbi Michal Springer. I know she's here somewhere. Yeah. Okay, there she is. Rabbi Joe Potasnik, who is not here because we know he's a little late sometimes to events. But we certainly appreciate his input as well. But, you know, it's really amazing, 7 months when we had our first call, and you start with a blank slate, and you say, well, let's have a conference, and who are we going to appeal to? And it's just so gratifying to have you all here today. I appreciate the support of our collaborating organizations. They are listed in your program as well. And it's really wonderful to have this community here, chaplains, clergy, of course, professionals in the field as well. It's really wonderful. And so I just want to talk a minute about Plaza Jewish Community Chapel. I know most of you know who we are, but for those of you who don't know who we are, we were created 13 years ago to be a true service to the community. Our mission was to ensure that every member of the Jewish community have a dignified Jewish burial, and that we provide support to families in need. And here we are doing just that. We are governed by a board of directors made up of clergy, executives in the social service field, as well as community lay leaders. And aside from the fact that our prices are significantly less, I think I can say to this group, the gestalt of Plaza is very different, because we have taken that profit motive out of the equation. So when families come to us, we meet them face to face, and we guide them through this process of caring for their loved one or family member or friend. So it is an honor for me to represent Plaza to you. I would be remiss if I didn't mention a couple of my board members who are here today, because they truly do so much to promote Plaza. That would be Alan Traeger of Westchester Jewish Community Services. He is chair of our Social Service Committee, so this comes under his committee as well. Bob Wolf of Healthcare Chaplaincy, who's also a board member. Rabbi Michal Springer, who is here. And two other members were to be here as well, but they are not here yet. So, before I turn you loose, a few things, housekeeping. Number one, for groups that are here, that would be members of Healthcare Chaplaincy, MJHS, National Association of Jewish Chaplains. If in fact, if you can do this quickly, after the conclusion of the keynote, if you would like to have a group picture taken with those folks who are here from your particular organization, please know you can step out into the hall. And Heather, where are you? There she is. She'll be happy to take, but it's got to be fast because we've got to get to our workshops. Two things. Please, in your packets, you will find evaluation forms. There's only one evaluation form, and even though you are attending 2 workshops, be creative. You know, just let me know what you think about your workshops. I didn't want to put in 2, waste paper. So let me know, and please turn them in. In addition to that, like us on Facebook. Plaza Jewish Community Chapel has a great Facebook page, and we would like you to like us on Facebook. Lunch is served back here between 12:30 and 1:30. And then closing thoughts by Rabbi Nancy Weiner will also be back here at 2:45, and that will last till 3 o'clock. So, my work is done. So the work is now up to you. And I admire all of you for taking time out of your day to be here, to enrich your work as you move forward on your journey of chaplaincy and caring for those who are in need. So it truly is my honor to introduce a dear friend of the chapel and a dear friend to your community, Mr. Howard Sharfstein. Thank you.
It is a blessing to be with you this morning to discuss this important topic, and especially at this time of year. Whenever I stand up to speak, I hear my mother of blessed memory saying to me, "Stand up straight, speak slowly." So I will try to do that. My words are called a reflection. They are not really a reflection, but it's the story of a journey from illness to recovery, a journey of discovery of myself. In 1992, at age 46, I was in the shower, and I felt a lump in my groin. And then I felt a lump under my arm. Now, typical of me, I would have said, it's nothing. It'll go away. It's an infection. But for some reason, I went to my doctor. Before I continue with my story, let me pitch to the men in the audience. Women do self-examination, and they act on what they find. Men are not good at that. Men need to do self-examination and react to it. And because I did, I'm standing here today. I went to my doctor. I'll never forget his face when he examined me. I was on the operating table later that afternoon for a surgical biopsy, and it turned out it was cancer at age 46. It was non-Hodgkin's lymphoma. I went to Memorial Sloan Kettering. I underwent a course of 4 months of high-dose chemotherapy. At the end of my treatment, they said we can find no trace of the cancer. After 5 years, which you know is a benchmark in cancer treatment, they said you're cured. To my surprise, 8 years after I concluded treatment, I found another lump. and it turned out it was a recurrence of my cancer. They had told me early on that non-Hodgkin's lymphoma, if caught early, is very treatable, and I proved that. They also said if you have a recurrence, that's a little funky. We're not so sure we do as well with recurrences as we do with initial diagnoses. So in the year 2000, I went back to Sloan Kettering for another course of treatment. Early in my treatment, I had to have a series of biopsies. The first one, I was sitting in the pre-op room in a hospital gown, which is one of the most demeaning garments in the world, in a wheelchair. And you were, at that time in Sloan Kettering, you were stacked, one patient next to another patient, next to another patient, all waiting for the operating room, separated by just a curtain. It was terrifying. I was speechless. My wife was speechless. Just at a time I thought we should have been communicating, we weren't. Then in walked a remarkable person. I was in a wheelchair. She was about my height, standing. It was a Sister Elaine Goodell of the chaplaincy at Memorial Sloan Kettering, a Catholic nun and a terrified Jew. And we connected. For about 8 to 10 minutes, we connected, and I opened up. I'll never forget it. And we talked. And we didn't talk about cancer. We talked about this. We talked about where I was here. We didn't talk about religion. We didn't talk about theology. We talked about what was in here. What was my fear? What was my concern? And I think for the first time, even before I mentioned it to my wife, I said to her, I think I'm going to die. I think this cancer is going to kill me. She didn't say, oh, no, don't worry, it'll be fine. We just kept talking. And when they wheeled me into the operating room, I felt better. Well, it turned out after the biopsy, I had a recurrence, and they said that what we want to do for you is a stem cell transplant. And back then, a stem cell transplant involved the harvesting of your own stem cells, months and months of high-dose chemotherapy, 2 months of full-body radiation, and then admission to the hospital, more chemotherapy to the point that you have no immune system at all, reinfusion of your stem cells, and hopefully you do not get an infection. Stem cells create a new immune system. I was in the hospital in isolation for 4 months. And during that time, I came to realize doctors have maybe 30 seconds for you, if you're lucky. And by that I mean, if they come in and examine you and they find nothing amiss, and you are, in their parlance, unremarkable, that's great. They're gone. Nurses are so tremendously overworked. If they have a minute and a half for you, you're extremely fortunate. So you're sitting there. I was in isolation. My wife, in fact, went into isolation with me so we could be together. And nothing. And then a man strode into my room. He was a chaplain. And he had unlimited time to sit and talk to me, to find out from me and help me say what was true for me as I went through that process of illness and recovery. When I was done, I decided to learn more about chaplaincy, and maybe this was something I wanted to do. I enrolled in clinical pastoral education at the Healthcare Chaplaincy, a remarkable organization. I've taken 2 units of CPE with the most remarkable of teachers, who is sitting over there, Rabbi Benita Taylor. She, too, changed my life. And in CPE, Benita said to us, the students, that we had to write what she called a personal theology on the signposts of a patient's mindset. We spoke about loss, grief, fear of the unknown, loneliness, abandonment, anger. And Rabbi Taylor suggested I write a personal theology about what she correctly discerned was my major issue, which was fear. My fear of another recurrence of my illness and my fear of death. And I just want to quote a simple paragraph from the the theology that I wrote. And to me, it sums up, for me at least, the interface of illness, recovery, spirituality, and ability for a patient to look within himself or herself. My theology on the matter of fear is that fear is now part of my psychological and spiritual being. Just as I have 2 arms and 2 legs, part of me now is the fear of the recurrence of my cancer. I guess we all have a menu of what thoughts pass through our minds. Some change day by day, others recur. My subconscious dialogue is often over the matter of the recurrence of my cancer and my death as a result thereof. Coming to that knowledge helped cure me. I hope, I pray, that I'll be closing out my career as a lawyer next year and returning to chaplaincy and maybe someday becoming a chaplain. So I thank you all for being here today to study and learn about this important part of healthcare and of return to life. Thank you. I also want to introduce Alan Traeger. Thank you, Alan.
Thank you, Howard. That was inspiring. So, it's 12 you were Stephanie. 12 years, 14. Every year they're terrific. One of the other reasons I come to the workshops, conferences, is the breakfasts are great. Yeah. So what happened this year is that there's now a lunch, and so with the breakfast. But I understand if the past is any indication, you guys are going to have a terrific lunch. So that got the most applause. Lunch. So one of the things that I'm a card-carrying board member of Plaza, and so I get the privilege of introducing the speaker. And typically we have a person who is a great leader in his or her field, as well as a wonderful speaker. But not unlike Mariano Rivera, whose CV is unbelievably impressive. The thing that made Mo an icon in baseball is the rest of him. And I must tell you that in my conversation with our speaker, we have Mariano Rivera in the CV, but a whole person with lots of other stuff going on. So we have a real MVP speaker this year. She's great. A seamstress, a cyclist. She actually showed me pictures of some of the baked goods that she's made with great pride. So she's terrific, and also a good sense of humor. There are a few things she said that I'm not allowed to quote, so I won't do that. Talk about a leader and an unbelievable CV. You guys have it, but just to name a couple, the Buehler Professor of Geriatric Medicine, the Director of the Buehler Center on Aging, Health, and Society at Northwestern, also an adjunct at Northwestern, teaching organizational ethics and economic resilience options. She's the principal and co-founder of Patient Safety Education Program, both in the States and in Canada. Founder and principal of Education and Palliative and End-of-Life Care Program. And in her prior years, principal investigator of multiple NIH and foundation grants, and vice president of ethics standards and founder and head of the Institute for Ethics at the American Medical Association. Actually, you and Mo have some really distinguished CVs, and it is with great pleasure that I introduce this morning's speaker, Dr. Linda Emanuel.
Thank you. Thank you, thank you. Does it work for you if I stand in front of the podium instead of behind the podium? I don't feel connected enough unless I'm in front of, I mean, without a barrier. So, good morning. Thank you very, very much for coming out today. Just being here, sitting at the table, looking around the room. You know, when you walk through life, and you see people's faces, my sense is that people look a little kind of like that. And here, you guys are like this. You smile, you connect with one another. It's beautiful being with you. So really, thank you, even before we've begun, for being here. I want to talk with you today about palliative care and another kind of togetherness. And this is a togetherness that has pained me for the duration of my time in medicine, which is by now quite a while. And the science that allowed me to do the trajectory that I've been on has been dissociated from the spirit that got me there in the first place. And so for me, it's a culmination, it's really a capstone. Like Howard, I'd like to close out my main portion of my career and create another one. And creating one in which the science and spirit come together in medicine is part of what I would like to be a piece of. And so being here with you today is really very special for me personally. And what I'd like to think that we'll be able to cover, we'll see how far we get. I hope you're very interactive during the course of this hour, so if anything is in your mind, speak up. But I'd like to cover what is palliative care. How many of you work directly in palliative care? A third of you? I'm going to go very fundamental about what is palliative care, which is intended to be relevant to all of you who are in palliative care as well as those who are not in palliative care. And then the place of spirituality and spiritual care in palliative care is where, of course, we want to focus. And then we'll talk about research that is beginning to get going in the spiritual needs amongst the seriously ill. Steps that are being taken now to create an entire new entity that is just the most exciting thing is where we'll begin to focus. And that may be controversial, and I want you to feel very open and free to discuss the controversial aspects of bringing these two threads together. Not everybody thinks it's a good idea, and so that's important. We need to be very cognizant about what we're doing. And discussion, of course, always discussion. So that's what I'm hoping to do in the next hour together. Sound good? Yes. A link? You're all welcome to it. There's nothing, there may be one or two slides that I shouldn't share until it's published, but I'll let you know which ones those are and give you, or whoever can pass it on to you. So I'd like to talk about the origins of palliative care, and I'd like to talk about the woman who has been my main heroine in my life. She's been absolutely inspirational for an enormous number of people, all of palliative care, I would say, and here she is. This is Dame Cicely Saunders, a remarkable, remarkable woman who was really the founder of the palliative care discipline. She was the founder and president of St. Christopher's Hospice in London, and she lived until 2005. And for me, that was the passing of an extraordinarily large and inspiring figure. But her inspiration didn't stop in the least. In fact, her inspiration is now greater, I think, than it's ever been. And here's what she inspired us with. She inspired us with a concept of palliative care that looks like this. She said that there are domains in a person's life, and every single one of those domains must be cared for in palliative care. Now, this is so simple. There's nothing important in life that's not simple. And she was nothing if not important, and so she was simple. Physical is the domain that most of us focus on in medicine. But she was not content with that. And psychological has struggled enormously to be brought into the field of medicine and has succeeded. It's still not as recognized and as respected as it could be, but it's there. She wanted more. She wanted the social aspects. She noticed how illness impacts the social aspects of a person's life incredibly. So she wanted all of that, but she wasn't going to stop there. She was the one who put spirituality on the map from the very beginning of palliative care. So this was her concept, and her concept that she encapsulated with the term that she coined of total pain defined palliative care. So total pain is suffering in the physical, the psychological, the social, and the spiritual realms. And that's what she noticed that her patients were experiencing. So that totality of experience was where she focused. And these circles were never again to be rent asunder from her point of view. So this is what happened in palliative care according to my sort of retrospective. After a long while, the World Health Organization understood the magnitude of what she was proposing and its significance globally. The importance of palliative care across the world was something that they really understood. So they provided a definition, and they said that palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness. Notice how they define that. All the problems associated with life-threatening illness. In fact, life-threatening illness is not what they're facing, right? It's the problems associated with life-threatening illness. The fear, the financial devastation, those kinds of things. Through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of what? Not the disease. Other people are already doing that very well. It's important. Palliative care accepts that that's extremely important. But we're focusing on pain and other problems, psychosocial and spiritual. So that's the World Health Organization definition, and Cicely Saunders really saw us through to the point where it was globally recognized. And just a little bit of a story, I like to tell her story, and her story about how this whole notion began starts with her story. So she started out life as a nurse, and she was a woman from a very well-to-do English family. And she was a nurse in World War II. She hurt her back, couldn't lift patients anymore. She hurt her back carrying wounded soldiers. And so she became a social worker because she couldn't be a nurse anymore, and was very frustrated. And she had a mentor who was a physician, and her mentor said to her, "Go study medicine because they won't listen to you unless you're a doctor." So there she was at age 33. She went back to study medicine, and she became the walking interdisciplinary team. She was it. She was everything. She got every single perspective. And she started with a tiny little group of people, patients who were dying, and the one who really touched her, they had a real love bond that she's very open about. The person who touched her was David Tasma, a Jewish man from the Warsaw Ghetto who was the sole survivor in his family, and then found himself dying of cancer, not able to understand why he had survived, only to die of cancer a few years later. And in this extraordinary relationship, he gave the £500 that he had as a insurance, and he donated it to Cicely Saunders to make a window, a stained glass window, in St. Christopher's. And it was really David Tasma who had the idea about what palliative care should be. So it's a very interesting legacy of the Holocaust brought on the shoulders of David Tasma, who had no children, had no idea why he had survived, and yet in retrospect, it's so clear that what he did was create a gift of untold magnitude for the entire world out of this dying conversation and dying relationship that he had with Cicely Saunders. So let's talk about this interdisciplinary team for a moment. And I put the patient at the top. I put David Tasmer in that story for a very important reason. Because the patient is the center of this interdisciplinary team of which Cicely Saunders was the inspiration. And the interdisciplinary team in palliative care doesn't work without the family and the community. So in palliative care, the unit of care is the patient, the family, and the community. It's not just the patient. We spend a lot of time in medicine currently trying to get the focus to be patient-centered, and yet it doesn't stop there. And so we need to be sure that we're really focusing on not just the patient, but the family and the community, because it takes a village. I was listening to a little bit of a snippet of a conversation about being a doula for the dying, and I was thinking, it takes a village. It really takes a village. And so there's the social worker, the psychologist, and the chaplain in the next line. But then there's also the support staff and the case manager and the administrator. Then you can't really do very much unless you've got occupational therapy and physical therapy and respiratory therapy. You certainly need the pharmacist. You certainly need the lab technician, the dietitian, the nurse's aide. You need for sure the nurse. And then you need the people who can write the prescriptions as well. So it's a huge army of people who are needed when it comes to a serious illness. And how do they fit together in this very simple 4 circles of palliative care that Cicely Saunders described? So I just threw all of those lists together in a kind of crisscross that intersects with those 4 circles. Because it kind of gave me a visual. I'm a very visual person. It gave me a visual of how we need to interact with one another. Now, one of the things that they say about the culture of medicine is that it is as tribal can be. It's true, right? I mean, I hear that chuckle of recognition. So we're siloed, we're tribal, and yet we need to work in this extremely interdisciplinary fashion. We don't even speak each other's languages often enough. I have this proclivity to try and be a cross-disciplinary polyglot, and it's a task. Everybody creates their own jargon, their own culture, and their own, it's almost like we've all got a secret handshake. You just can't get into somebody else's area unless you have the right kind of entree. So difficult, very difficult to create a discipline for a concept of care that is at its core interdisciplinary, holistic, and this is what Cicely Saunders was up to. So here we are again with her total pain, suffering in all the dimensions. And here's a rendition of what palliative care should be able to do if it works well. So this is kind of a graphic rendition, graphical rendition. So the patient presents at the beginning of that middle rectangle, and his or her needs kind of wax and wane, and you can see the patient care needs a dotted line, until all the way at the end, the patient dies, and so the needs escalate up until the end in some fashion. It doesn't have to be that undulation. The point is just that it goes up and down. And the palliative care team hopefully kicks in very early on. Sometimes people end up in hospice towards the end. Sometimes they don't. But the notion here is that curative and remissive therapy can and should carry on as long as it's relevant, so that a person can have a blended involvement of palliative care from the moment that the illness presents. And you don't have to make a choice as to which type of care you're having. Another thing that's shown on this diagram that I want to bring your attention to is the line which is a full straight line, which is about functioning. Because the dotted line at the top, which is the straight line, is the caregiver, and the family caregiver is functioning in society without any direct connection to the illness, provided only that the patient is not in need of a great deal of care. So a lot of the impact of serious illness is on the caregiver, as you know very, very well. And so this straight line at the top is highly idealized. And it is the product of what palliative care is ideally supposed to do. And I'm going to show you, I'm going to introduce you to some of the patients who I've known over the years in a moment and show you how this really is not just a dream, but something that is entirely possible. Because the full line, if you see the patient functioning in society, although the patient's needs have gone up and down, if the patient is supported by palliative care and all his or her symptoms are really well managed, he or she can function in society until very close to the end, when his or her attention turns to having a quality dying process, which we'll talk about. So if the patient is functioning that well, then the caregiver can function that well as well. And you see that kind of well-being increasing sometimes all the way until the end, and allowing people to have a quality grieving process that keeps them functioning in society as well. So that's the idea, and that's a product of the conception that Cicely Saunders provided for us. So I want to introduce you to a few patients. This is a gentleman, we worked with our colleagues in India for quite a while. We still work together. And this is a patient who I met when I was with them. This was in Trivandrum. Rajagopal is the name of the person we worked with. And this is one of their patients. And this gentleman was absolutely immobilized from his pain until he hooked up with hospice, and then with pain management was able to get up, and you can see on the right-hand side that he was up and around. And as soon as he was up and around and able to care for himself, his wife, who's one of the women in the circle with Dr. Rajagopal, who's the gentleman there, was able to start working with hospice, get some additional training, so that when he did eventually pass away, she was able to get into the workforce and not descend into destitution. So they had this connection between what the patient needs and what the family caregiver needs, which we don't pay that much attention to in this country, and we certainly need to. And for heaven's sakes, they were doing it in an area where there were no financial means to speak of, nothing that would even fit on our ledger books here, and they managed to do all of this. So for those of you who are squeamish, I'm going to introduce you to a gentleman who it looked so extraordinarily shocking that you might want to close your eyes if you are squeamish. And this is he. He came from Hospice Africa, Uganda, and he had HIV/AIDS, and this is advanced Kaposi's sarcoma. Now, he was living in a small hut outside Kampala, and notice that his bandages were newspapers. It was very hot. There were flies everywhere. Notice that there was not a single fly on this gentleman with open wounds. He'd been in this condition a very long time. See, his arm has these contractures, very wasted. So he'd been in this condition for a very long time. Extraordinarily devoted wife. He was a school teacher. And this was about 7 days before he died. And he asked that we take this picture. A colleague of mine took this picture, and he asked that we use it as widely as possible because he had a message. And his message was this. This was what he felt like after he had received hospice treatment. He was so full of gratitude. The only thing hospice did for him was take care of his family in very practical ways and give him morphine. That's all they had. So he wasn't in pain. Wonderful, wonderful man. And so we're honoring his dying wish to be a teaching inspiration for as many people as we can put him in front of. So here he is. Another person I want to introduce you to is Kit Meschenberg. Kit Meschenberg also asked that her story be used as a teaching story. Kit Meschenberg came to me when we were just beginning our education program, and we have an education program for palliative care, which is national and international. And she came to me when we were just beginning that program, and she said, well, the first thing I want you to know is my name is Kit Meschenberg. The second thing I want you to know is I have cancer. And the third thing I want you to know is you're about to give me the job I want. She wanted to run this program. I gave her the job. What was I going to do? She was the most extraordinary program director. She lived 2 years. And here she is with her husband on the right-hand side as her adenocarcinoma of unknown origin progressed. You can see her hand was already in a bandage. She had lymphedema from having had her nose dissected. She was in a wheelchair. That's her daughter, who was reading to her in her last week. And there she is with her grandchildren a few days before she passed away. And so she worked until 2 months before she died, and she chose to work. That was her mission, to work for all of that time until in her last 2 months she turned her focus to the personal work of dying that just made her magnificent. And I can't speak about her without getting goosebumps, which I've got all over my body right now, because she was just so inspirational, just spectacular. All of the people I've introduced you to were just spectacular. In fact, I have not met a dying person who was actively engaged in his or her dying who was not inspirational in that fashion. You know that. You do that. So I just wanted to introduce you to these people because they led the life of that ideal curve. They really they led life as they loved it, to the fullest, to the moment they died, and they passed that baton to the people that they loved so that they would continue to live that life that they love and that's inspirational. And they could do so because of palliative care. Now, does that make Cicely Saunders the greatest woman ever or not? It does, doesn't it? What could medicine possibly want to do more than that? Nothing. That's it. That's it. So I'm going to get a little bit academic now. So palliative care has reached a point now where we started out in hospice because that's where Cicely Saunders wanted to start, because she was aware that mainstream medicine was not going to accept what she was talking about. It was too radical. It was too whole. It was too funky. It was too spiritual. It wasn't going to fly. So she started on the fringes of medicine. She had a freestanding hospice, St. Christopher's Hospice, and that's how she made it work. And then Balfour Mount, an extraordinary surgeon, Canadian surgeon, took the same concept and made it live in Canada, and that's how we got the term palliative care. It was essentially the same idea, but because Balfour Mount was in mainstream medicine, palliative care became the term that was used for the kind of total care that is integrated within mainstream medicine. So that's how the terms became sort of distinct, although they started out as synonymous. And now we have all kinds of interesting discussions going on because the hospice establishment is now fully alive and integrated. You see hospices on every corner. It's a household term. Everybody knows what it means. 30 years ago when I was beginning, nobody knew what hospice meant. Everybody now knows what it means. In fact, I'll tell you one more story, can't quite resist. Amongst the things I like to do along with bread making and whatnot is I like to throw pots. I'm a potter, a bit of kind of a funky potter, but I like it. And so I was in my pottery studio. I just like, have little rented time space. So there were other people all around, and there was a woman talking with another woman. They were also throwing pots, and one woman was saying to the other this, that, and the other about her father. And her father had recently died. And the friend was saying, well, so how did it go? And the woman said, oh, yeah, he had hospice and all that, and that was great. And then she went on to talk about other things that mattered to her. And I thought, oh, yeah, he had hospice, and that was great. What? That's amazing. It's just everyday expectation. Oh, yeah, he had hospice, and it was great. That's what we wanted, right? We've arrived somewhere. So that, to me, that was like, okay, all right, do something else with your life now. This is it. It's happened. It's happened. So now it is fully integrated. It's there. It's available. We have other very serious problems that we need to talk about. And here's just one of the discussions, and that is whether we should be dropping hospice and integrating it into palliative care. Whether if you bring palliative care all the way upstream, and you really start it at the beginning of every single illness. Say I get a diagnosis of rheumatoid arthritis tomorrow, I start palliative care right away. My prognosis is probably 15, 20 years, I hope. I haven't got it, but if I were to have, that would be a wonderful vision for how palliative care could work, right? And then once, say, down the line, I've got rheumatoid arthritis and my cervical vertebrae is really, they're really falling apart. And I saw this with my beloved aunt who died of rheumatoid arthritis, extraordinarily difficult disease. And at some point, she had to, as Kit Meschenberg used to call it, my aunt had to throw herself over the wall of hospice. She had to say, I'm dying. I'm going to give up on the curative treatment. I'm going over to the other side. That's a very difficult decision to make. And no one should have to choose between fighting to live and having pain well managed. That's just a terrible, terrible choice. So this is the discussion that's been going on recently in palliative care, because on the one hand, we all want all the benefits of palliative care to be integrated into all of medicine. And on the other hand, if palliative medicine goes too far upstream, will end-of-life care sort of disappear from focus, and all of the intensity and the roles and the work of dying well and being douled through it might lose its focus. So that's what we've been worried about, and personally what I've been worried about as this new definition of palliative care has come into play. There's been no mention of spirituality. So that is a really, powerful reminder that we have to, success is a problem sometimes. And we have to realize what we lose when we reach the point that we've been aiming for, and look around and make sure we've got everything with us that we'd really wanted to bring with us. So in honor of Cicely Saunders, it felt like something that was beholden on all of us, and me included, to make sure that we didn't lose that fourth pillar of palliative care. I did want to introduce you to one more person, because this was a woman who I met in Kampala, outside of Kampala, Hospice Africa, Uganda. And this was at a caregiver respite program. That once a week they had a respite program, and people would come. And she was just sitting there in the wheelchair, and I wasn't sure whether she was a patient or a caregiver or a revisiting relative. What was she doing there? What do you think? Well, she was both. She had reportedly a rare tumor in her spine when she was young, and they operated on it. It wasn't really clear. There were no records. It wasn't really clear that it was a tumor, but they made her paraplegic from the operation. And her father was dying of HIV/AIDS, and she was the caregiver for her father. And so this young lady became a permanent fixture at Hospice Africa, Uganda. They saw her through her education. They made sure that she was carried by her classmates from one class to another. She was a spectacular individual, and she's probably about 18 now. Okay, so back to Cicely Saunders. This is the slide you've seen before, but I just wanted to add in the bottom line, because looking back from where we are, where we've arrived, where hospice is a household term, and have we got everything with us? Do we have our fourth pillar? Did we bring all our bags? No, we've lost spirituality. What are we going to do about it? I just want to put the idea forward that Cicely Saunders was perhaps also the first science of spiritual suffering, a scientist of spiritual suffering in modern medicine. Just maybe. Just want to pose that idea, because she had spirituality there as part of her model. She had a very clear and simple mental model and the mental model that allowed this whole discipline to arrive, complete with a body of knowledge and a body of research. So let's take a look now at the research that has happened over the years in palliative care, please.
Madam Cicely used the term palliative care.
She used hospice, she used palliative care. Back then, palliative care was more the American term, so she didn't use it very much, but it was, during her era, synonymous with hospice.
Language is so important.
Yeah.
And what I've noticed is that in all of your slides so far, the word hospice has not really appeared, but the word palliative care. And when I remember Bill Moyer's series
Yeah.
of Dying Well, or
Yeah.
whatever it was called,
Yeah.
I think it was only doctors. There was one nurse, the balm of Gilead.
Yes.
It was mentioned.
Yep.
And any of the other circles were essentially not represented.
Right.
So my sense is that by using the term palliative care, what is happening is it becomes heavily focused on the medical profession.
Yep.
And so I wonder why you don't, why the word hospice
Is less there than palliative care. It's aspirational in that I want palliative care to become interdisciplinary and whole person, family and community focused. That's a choice I've made as a matter of preponderance, not as a matter of dichotomous choice. Hospice also means, it means a Medicare benefit, it means a place, it means a certain kind of institution and a certain kind of service. So palliative care is a little bit more encompassing, so that's why I tend to use that term. But it's evolving, and it's a choice, and you create what you speak, and I completely acknowledge the importance of what you're saying. So maybe I should, hospice and palliative care, maybe I should say the full mouthful. Thank you for that point. So let me just go through some of the kind of bird's eye view things that have been happening in research in palliative care, and a lot has happened in research in palliative care over the last 20, 30 years, especially in the last 10 years. So by now we know a great deal about the physiology of pain. We know about mu receptors. We have all kinds of medications available for it. There's been campaigns so that pain as a fifth vital sign is panoramic. We're very, very good at pain management. The social science and philosophy of advanced care planning got a great deal of research and attention about how to think about and how to do the withdrawal and withholding of life-sustaining treatment in a way that is ethical and in a way that is manageable within the system. Lots of research on other physical symptoms so that we're now pretty darn good at managing all of the main physical symptoms that tend to afflict the dying, and there are many. There's breathlessness, fatigue. People often don't think of fatigue as a form of physical suffering, but it's certainly a form of physical suffering for anybody who's been too weak to lift a limb. That is painful. Nausea, terrible. Anorexia, weight loss is a form of suffering. Constipation, anybody who suffered from that, is extraordinarily problematic. Itching, wound management, all of these things now, we are really good at this stuff, very good at this stuff, to the point where you should be able, I don't want anybody to, but one time or other in our life, most of us will be in a situation where we might have 6 or 7 or 8, even the average is actually 13 of these symptoms when we're seriously ill, and wounds, bed sores, cancer wounds. We should be able to have all of that managed. And if we so choose, we should be fully functional, including in the workplace if we want to. Depression and anxiety, major part of the suffering of palliative care. We now have a great deal of research on depression and anxiety, including for people who are on multiple medications. It's possible to treat depression and anxiety very effectively. I was absolutely in awe of the physician who took care of Kit Mischenberg. She did not have a day of depression, and her anxiety was extremely well managed as well. Many of you here are professionals in bereavement, and of course you're all here at a bereavement conference, and you are doing wonders. There are people who are able to have profound grief, but it is healthy, non-complicated grief, and they are able to rebound and live life again in a way that has not always been possible. We've had research on goals of care. We're now getting into really good research as to how to orchestrate a family meeting so that it really works to meet the needs of families. And so all of this research is progressing, and I'm intensely proud of this. It's just phenomenal what our colleagues have been able to do. But what's missing? Where is it? Where is it? Gone missing. And in modern medicine, no data, no see. It's not there. We have to have data if we want our spiritual meaning to be given its due. So how do we think about it? Well, Christina Puchalski, who I think many of you probably know, has been one of the people who has really pushed this. And as a physician, she has been able to get some traction. I'm not sure what proportion of practicing physicians know what FICA is, but a decent proportion. Nowhere close to what we would like. But FICA is just an acronym, as you know well, which people can use to just inquire of a patient what their spiritual state is and what they can do to be helpful. What's your faith? How important is it to you? Do you have a faith community? And is there anything I can do to address any needs that you have? Not much to ask. Very clever the way she's put it together so that it should be possible for a cardiologist or a neurosurgeon or an admitting nurse, anyone, all busy. Howard's vignettes were so absolutely accurate, 30 seconds if you're lucky. And they should be able to say that. They should be able to ask that and make an appropriate referral. Now, what was also so striking to me about Howard's story, absolutely characteristic of other people's experience as well, we have a fairly large number of physicians per patient, and we have even more nurses per patient. In my hospital, we have, it's a 500 and something bed hospital, and I think we have 5 chaplains. How is it that the chaplain walks in and seems to have all the time in the world? How does that work? What do you guys do? Where do you make time from? It's amazing. I mean, I totally take my hat off to you. You guys know how to listen in a way that makes a person feel like you have all the time in the world and that they can be open. Why don't our doctors know that? Why can't they listen like that? Why can't our nurses listen like that? There's nothing in cardiology, there's nothing in general internal medicine that prevents me from listening like that I know of. But nobody taught me how to. I'm a general internist by background. So Christina was trying to get us to do a little bit of that. And some other people have been fantastic in trying to bring some measures into play. And Dave Seller and George Fachet, who many of you know, they created a measure for spirituality so that people could do research on it. And Karen Steinhauser, she decided, all right, let's get it down to one question. One question. She validated it. The question is, are you at peace? Incredibly high sensitivity, high specificity, really good question. And so that's now become an item. That question is a measurement item. So those have been good. It's kind of paltry by comparison to the masses of research in other areas. We've gone a little further. In 2009, we had a meeting about defining spirituality for palliative care that George Hanzo, who's over there, was part of. And There was another task force on spiritual care in palliative care in Europe, and they came up with a definition. So let's talk about a definition, because definition is very, very important. Because when you have a definition, then you can start thinking very clearly about research. Let's talk about what it's not to begin with. It's certainly not physical well-being, or is it? Of course it is. It's certainly not social well-being, or is it? Yeah, it is. And mental health, also not mental health, and yet it is. So it seems to be connected to all of the above. And I think that we'll find when we get to the definition that one of the things that's really prominent about that definition is that spirituality has bridges to every other domain. And that may be one of the things that's most central to the definition of spirituality that those of us who are interested in research might want to think about. Nature maybe has these essential bridges, and maybe those essential bridges is part of what spirituality is about. So here's the definition that came from Pasadena, California in February of 2009, and it was published in Journal of Palliative Medicine in 2009. I guess the Archstone meeting itself was probably earlier than that. Spirituality is the aspect of humanity that refers to the way individuals seek and perceive significance and the way they experience their connectedness to the moment, to self, to others, and to the sacred. You familiar with that definition? How do you feel about it? Pretty good? Not so controversial. The Europeans wanted to make a slightly different version of it. It's the dynamic dimension of human life that relates to the way persons, individual and community, they wanted that community piece in there, experience, express, and or seek meaning, purpose, and transcendence, and the way they connect to the moment, to self, to others, to nature, to the significant, and or the sacred. Any controversy there in that one? People feel pretty strongly about that word sacred. Anyway, so there's a definition, and finally we have a consensus-based definition. Whether you use the European or the US one, it is a consensus-based definition that is published, and we can use it, and we need it. I'd like to spend a little time talking with you about where all of this fits in the way in which we do research. And what I'm going to move through fairly fast now, because I've taken a little longer getting to this point than I wanted to, is the kind of research that we've been involved in the central subject matter, which is really spiritual, the notion that there is a kind of way in which the spirit works. Whether you call it a physiology of the spirit or a mechanics of the spirit, but there are ways that the spirit works, and there are ways that the spirit doesn't work. And so that's what we want to study. How does the spirit work in the palliative context? And when is there that well-being that we seek for ourselves and our patients? And when is there a form of spiritual distress that we want to make better? The analogy being pathology. Now, we may resist that, and that's part of where we may get into some discussion. But when facing death, I think there's such a powerful sense that some people really suffer, and that we might call enough pathology that we want to help them with it, and we want them to have that kind of well-being. So it's a slight recast on what research might be, but it's not that much of a recast. And so really what we're looking for is the analogy in the spiritual realm to the physiology in the physical realm. How is it, and see this guy I put up here? You guys remember who William Harvey is? He's the one who discovered that circulation is how blood works, so that it goes round and round the body. And so he was the first physiologist, basically. And so if there is a workings of the body, there is a workings of the spirit. And how can we understand that enough to give more guidance to chaplains in doing this extremely important work. And so here's coming back to where I wanted to suggest that Cicely Saunders maybe was the first scientist of the spirit in palliative care. Because these circles suggest a kind of physiology of the spirit that fits with the definition. And so we had that word connectedness. We had the notion that all of these domains are part of spirituality, the community as well. The sacred was right there in the center. Meaning making was there. So this definition and Cicely Saunders' model sort of suggests that maybe the spiritual life provides a kind of integrative function, working between these four domains, attributing meaning and connecting our existence to the grand narrative of existence. So if that's what she was telling us, we have something to work on. And we have a whole bunch of methods as well. So for many of us who are old enough to remember, when social science and psychology was just beginning, people would say, subjective, can't measure it, don't even go there. It's the tree huggers again, you know, it's the funky stuff. And I'm a tree hugger, by the way. But they came up with methods that are very rigorous. Grounded theory, content analysis, psychometrics, observational psychology, these are all disciplines. Psychoanalysis, a whole discipline. Neuroimaging is closest to something concrete that our real biomedical scientists would respect. But all these methods are available to us. So if they could do it for psychology, I don't see why we can't do it for spirituality. So let's just think about what neuroimaging showed us. And it's been kind of interesting. If you do a functional magnetic resonance image of people who are happy and have enthusiasm, it's the left cortex that lights up. With anxiety and sadness, it's the right cortex that lights up. And the mediators enhanced left-sided activity and led to different decisions. So we're beginning to see that we can watch what's happening in the brain when emotions related to spirituality are happening. So we might be able to get a physical substrate on which spirituality is experienced. Prayer, interestingly, is not clear. There isn't one place that lights up when people pray, but when people meditate, it's quite clear. There is enhanced left-sided activity. And so that's a very interesting. Yes, please.
Is this the same research? It was a few years back that something, it was a science and theology or something, an article came out about neuroscience being able to explain the physical understanding of the existence of God in the brain. Do you remember?
It was a few years ago, so it probably was the same, and I would have to go dig in my references to find, but I'd be happy to do that. And there was a lot of discussion then about, is this God in the brain? The way I think about it is that we have the physiological substrate in which this is experienced. And that's very different. So I'm only looking at this as a physiological substrate in which our experience is happening. I don't find that in the least bit threatening, and I find it much more grounded than the idea that we've got a physiology of God in the brain. So the postulate that all of this comes from, for me, is that maybe spirituality is a network of, no, that's bad language. Maybe spirituality is experienced on a network of connecting neurons consistent with the integrative function that Dame Cicely Saunders' model suggested to us. Just maybe. So this line of research, I think, is very interesting. And there's another whole series of research studies that have been done on dignity therapy, which I imagine that you're all familiar with. So I'm going to run through that really very fast. Dignity therapy was designed by Harvey Chochinov, young psychiatrist, convinced that he really wasn't a very spiritual man, created an intervention that I think works wonders in the hands of chaplains and is an extremely spiritual intervention, which I think he's beginning to agree with. Not because I persuaded him, but I think he's beginning to say that also. So he noticed that when he was talking with people as a young consultant psychiatrist on the surgical ward, he was being sent to see people who were supposedly depressed. He would walk in and talk with them about their life, and as part of trying to diagnose whether they were depressed. And by the time he walked out of the room, if they were depressed when he walked in, they were certainly not depressed when he walked out. So his question was, well, what did I do? and what he noticed was that people were telling their stories. And so he noticed that telling stories, especially near the end of life, is a very important part of the dying role. And so he codified it in a manualized intervention that he then did a large number of randomized controlled trials on in 7 different languages, and found that it had tremendous impact on people. So this is it. This is how he manualized it. And here are the 10 questions that he asked. Very ordinary questions that I wouldn't be surprised if you folks ask in a fairly routine fashion. So there they are. And these slides are, of course, all available to you. No, this is all published. So his intervention intact and established by all gold standards, really the question is why? And my notion is that people were trying in westernized medicine, which was not conducive to it, to enter the dying role. And they were trying to perform the functions of the dying, which is how people connect with the living that they're leaving behind, and in a very sacred part of life. And in Western medicine, we were tying them up with tubes and not letting them go home, and they weren't able to enter the dying role and do what they needed to do. And Harvey Chochinov was letting them do at least one piece of it. You know, people would rally in order to finish this intervention before they died. So you know, these dying roles, I think, are tremendously, tremendously important, and understanding what they are is another area of research that we need to get into. Roles that are connected in life, that guide us in unknown territory, connect us to others. They usually come with tasks and jobs. And so the question of whether there is such a thing as a dying role, to my surprise, was contested. So we wrote a paper on it, saying, yes, of course there's such a thing, and here's all the reasons why. Life story is spiritual, it's a legacy, and telling is one of the tasks of the dying role. So that's a chapter in research in spirituality that's happened in palliative care that I think is a rock for us. I do want to tell you a story that happened with a young chaplain in training. Happens to be my daughter. I've told this story before. I haven't told people before that it was my daughter, but now I'll tell you it was my daughter. She was a chaplain in training. She was at Shaare Zedek Hospital, and she was taking care of Mr. N. And he was a Palestinian man. He came from Nablus. He wasn't able to get much contact with his family because it was very difficult crossing all the barriers from Nablus to Shaare Zedek Hospital, which is on the Israeli side of Jerusalem. So there she was, a young Jewish girl, quite orthodox, working in the interdenominational chaplaincy that's at Shaare Zedek Hospital. She made contact with Mr. N, to whom she'd been assigned. Mr. N didn't want anything to do with her. She kept on saying hi. And he got sicker and sicker, and eventually he started just letting her sit there and talk, and they got to be kind of connected. And she tells a story about how eventually his daughter was able to make it through, and Mr. N, who was a very proud man, not a man of many words, eventually, sitting there with his daughter, managed to sing A Jet Plane Leaving. That was his favorite song. And there were just tears streaming down his daughter's face, and his as well, and my daughter's face as well. And that was the only interaction that he had with his family during her stay. So it came to the time when he was really very weak, and he'd called her over, and he said, I want you to do something for me. She said, what is that? He said, I want you to tell my family something that I never told them, and I want you to travel to Nablus to do that. She said, what is it? She said, I never told them that I loved them. So there she was, this Orthodox little Jewish girl, crossing over to Palestine, going to find Mr. N's family, with this message that she described as something she was holding in her hands as a piece of sacredness. So she went and she gave this message, and they bonded, of course. I mean, how could they possibly not? And a year later, I went to visit her in Jerusalem. I met this family, and they came over, and we all had picnic in the gardens under the Church of the Holy Cross. So they were just like, what? Anyway, it was beautiful, and there's this this thing that just lasts and lasts and lasts. I couldn't quite not tell you that story. Dying rolls, we pass them on. They're symbolic, material, narrative meaning, huge blessing. Blessing. Where's blessing in medicine? All of that was about blessings and planning dying. All of these things we need research on. We need research, too, on something tremendously intense that I think we have so much research available to us that we can build on. Illness is a kind of spiritual trauma. People who have a life-threatening diagnosis feel abandoned. They feel traumatized. Sometimes, not everyone. Why some do and why some don't is not clear to me. But what is clear to me is just witnessing people who are suffering not because their cancer is causing them pain, but because they don't know why they've got it. They don't know why God turned God's face away from them. That's the suffering that's traumatic. Now, we have a lot of research now available to us about post-traumatic stress disorder and what happens in that kind of psychological trauma. And the similarities between the two strike me that there, with good research, there's a lot of richness there for us to understand why people sometimes have resilience to trauma, to war-related trauma, to other kinds of trauma, and what makes the difference. Now, one of the things we know from here that we must capture is that when a person has faced trauma and they come back and they tell about the trauma, if that trauma telling is not witnessed properly, that's a second trauma. So, if a woman is raped and comes home and tells her parents, I was raped, and the parents say, well, what were you doing out there? Or, tell me another, you're such a, loose woman, or something, like that, which happens. That's a second trauma. Now, we've got people facing the trauma of life-threatening illness, and what do we say to them when they say, I'm scared? Not you. But what do my people say to them? Yeah, oh, stuff and nonsense, you'll be fine. I think we're causing a second trauma to our people when we do that. And I think some research could solve that. So those are the kinds of things that I feel that research can really do for us. So our response really matters. And if we could just understand the kind of listening that you folks do and teach it to my folks, then we could allow people to co-create a narrative that would be balm to their suffering instead of a second trauma that locks in the first double time. So there's real need for research now, just to reach my people who were deaf to what your people are doing. Some colleagues and I did some work on adjustment to loss, and we integrated all of Cicely Saunders' domains and talked about comprehension phases and creative phases and reintegration phases, and these are things that you know about and you work with. But trying to understand those potential mediators is another whole research enterprise. It's a lifetime in and of itself, and I'm just putting that up there to illustrate the kind of research that's available for us now. Now here's just another kind of research that I wanted to show you. What's this map about? What does that belt across the middle of the country look like? It looks like the Bible Belt, doesn't it? Well, it's not. This is what it is. Isn't that interesting? Did it ever occur to you? It occurred to me looking at that map for the first time that all the differences between us politically in the way we want to be treated at the end of life is really a spiritual matter. I mean, we've known about religious feelings and the big controversies around the end of life and granny killing panels and all of that kind of stuff. But to think about this as a national spiritual discussion of a profound nature that we can have mediated by chaplains as a way of addressing suffering at the end of life is presented by this. So I put this slide out there just to give a sense that the field of economics has something to do with the field of research in spirituality and palliative care as well. The darker ones are more spending. So, so the Bible Belt is spending more money at the end of life than the coastal populations. This is just Medicare spending.
I'm sorry, just not sure I'm making the connection.
So these could be Republican, Democrat, it could be spending, or it could be religiosity, and they just look like the same map. So there's a deep connection between those things. And so there's something deeply spiritual about the way people make decisions at the end of life. And I don't know what it is, but it's making a huge difference to what people do. So the notion that we as a research in spirituality community have something to look at and ask about is really what I was trying to say. Yes, please.
Have they also compared this map with availability of hospice and palliative care services in that area?
Not to my knowledge. Very interesting, but I think that the availability is pretty uniform across the country, except perhaps rural areas, and there may be a correlation with rural areas, but even there now. Interesting. Lots of questions. So there are the takeaways from the discussion so far, mine, and I'd be very interested in yours. The imperative is really, really there. We've got fellow human beings who are suffering spiritually as a result of having a serious illness, and we may be making it worse, not better. We, my people. And we may be locking in their spiritual trauma instead of being therapeutic about it. So I believe that the time has come for the spirit and the biomedical scientists to join. The methods do exist. We can build on them. People are building on them, but it's just beginning. So that is a dawn of a new discipline that's right here for us to shape and make into something really special. We need the definitions. We have the definitions that we can begin with. We need some key questions and bold hypotheses, testable models, and I'm going to close by showing you what some people are doing now to take us into this new era. Here are 6 studies that have been funded by the Templeton Foundation through the healthcare chaplaincy. And these are groups of very rigorous, well-trained, accomplished researchers from Duke, Emory, Advocate, Children's Hospital in Kansas City, UCSF, and Harvard. And they're all asking a variation of the question of what is it that chaplains do? We want to know what you guys do. We think you do something really, really important, and we want to know what it is. So they're asking that question, and many of your colleagues are working with us. These teams are all one scientist and one chaplain at the lead of those projects. And this group is also working on a model that should be able to generate hypotheses that can be researched. And the model is one that says that the connections, that sort of integrated connectivity that we talked about in the Cicely Saunders model, when there's an assault to the system, such as what happens when you have a terminal illness, there's a perturbation to the system. And we looked at this and started creating both a mathematical model and a visual model. And in this visual model, we have the social, physical, psychological, and spiritual in the Cicely Saunders fashion, placed in the cosmos, and that spirituality piece is creating the integrative function there. And so we started to define the spirituality function using the definition, the consensus definition that you know and saw earlier, and defining the cosmos in a way that every approach to spirituality can feel okay about. All religions, no religions, spiritual approaches, and those that claim no spirituality. So everybody's got a word in here to understand what we mean by this greater entity. So it's very inclusive, talking about what the social context is, the physical and the psychological, and it's the interaction, according to this model, that we're studying. So that's the model. Those are the people who have trodden out into the pristine, uncharted territory of research that brings spirituality and biomedical research together. And that's where we are. Thank you, thank you, thank you.
So when I say it's a privilege to have an opportunity to be here with folks like Dr. Emanuel, I'm not kidding. 3 quick comments. One of the things we have to add to your CV is great wisdom. The second is it's really great for me to start my week off feeling that it's kind of Hanukkah and Christmas because you just gave us a present. So thank you very, very much. That was just great. Unfortunately, time is short, and you can tell she's a very accessible person, so your questions and concerns will find a way for people to be able to get to you with questions, issues, et cetera, either by email, phone call, whatever.
Yep.
Thank you.
Thank you. Thank you so much. Just a quick hello. I know that Reverend Eric Hall, who is the new president of Healthcare Chaplaincy, is here, so thank you very much and welcome to this community. So, workshops begin at 11:15. You have 7 minutes to get there. All workshops are on this floor. Again, lunch will then be back in this room at 12:30. So again, Heather will be outside to take quick photos for groups if you would like, and have a good time, and I'll see you back here for lunch. Thank you.